Welcome to the Mad in America podcast, your source for science, psychiatry, and social justice.
Hello, my name is Robert Whitaker, and today I have the pleasure of speaking with Adam Urato and Joanna Moncrieff. But before I introduce them, I'd like to provide the context for our discussion today. On July 21st, the FDA convened a hearing on the subject of maternal use of antidepressants during pregnancy and the impact this use has on fetal development. Around 400,000 children in the United States are born each year whose mothers took antidepressants while pregnant. And so I think it's easy to see the societal importance of this topic. What are the risks to the fetus, the newborn, and really for the long-term development of that child? Adam Urato and Joanna Moncrieff were members of that FDA panel, and so too were several others well-known to MIA readers, including David Healy and Joseph Witt-Doerring. The purpose of the panel was to assess whether the FDA needed to put a warning on antidepressants related to their use in pregnancy, and most on the panel spoke of research that told of the need to do so. However, after the panel concluded, the American Psychiatric Association and other medical associations, most notably the American College of Obstetricians and Gynecologists, responded with what can only be described as howls of outrage, issuing press releases and telling the public that the panel was biased and that the real risk during pregnancy was untreated mental illness. These medical organizations asserted that the increased risk of adverse outcomes for children born to depressed mothers is due to the illness and not the drug, and that there was plenty of evidence that antidepressants were a helpful and even life-saving treatment for maternal depression. So here's where we are today. That FDA hearing put two narratives on public display, and most media reports embraced the narrative put forth by the medical organizations. And what we will do today in this podcast is review the evidence that exists on this topic and the response by the medical guilds to a public airing of that evidence. Now, Dr. Adam Urato is Chief of Maternal and Fetal Medicine at the Metro West Medical Center in Framingham, Massachusetts, and he has been speaking and writing about the risk of medication use during pregnancy for years. Joanna Moncrieff, Dr. Moncrieff, of course, is a UK psychiatrist and researcher who was a co-founder of the Critical Psychiatry Network, and is well known for her research on the safety and efficacy of psychiatric drugs. Thank you both for joining us today.
Thank you. Nice to be here.
Thank you. It's great to join both of you, two trailblazers and legends in the field. It's a real pleasure to join both of you.
So, Adam, I'm going to start with you. And the question is, do you know how this panel came to be?
I think several things are going on that have kind of prompted this. One, just as far as antidepressants go, there's rising rates of antidepressant use, particularly antidepressant use during pregnancy. So we're seeing more and more of that. And I think concurrently with this, the research evidence has continued to roll out on this now over the last 4 decades. Evidence of harms and harms to the developing baby and pregnancy complications. And I think that certain individuals in the current administration and at HHS are interested in this area, and so they had wanted to put some focus or attention on this topic, which, from my standpoint, was sorely needed.
Joanna, how about the view from the UK? Is this a topic of concern?
The mainstream view in the UK is very much the same as the American Psychiatric Association opinion that came out after the FDA hearing, that women shouldn't be frightened of using antidepressants during pregnancy and that depression should be treated just as robustly as in people who are not pregnant. But I think, as I'm sure has been happening in the US, increasing questions have been arising in the public's mind about the increasing use of antidepressants, partly because of just the huge numbers that are now using them. Almost a fifth of the UK population are taking an antidepressant. That's what the latest data suggests. And of course, Irving Kirsch's work has been raising questions about whether they have any benefit over and above their placebo effect for quite a few years now. And then we published our paper on the serotonin theory of depression and the evidence for that, suggesting that the evidence didn't support that idea a few years ago, which I think, caused a lot of people to ask the question, well, why on earth are we using these drugs in that case? And what the hell are they doing to us?
Well, it's obviously a topic of incredible societal importance. If you have evidence of harm done, of increased risks, That's an extraordinary story of public health. Evolution over a long period of time obviously created this miracle where you go from a fertilized egg to a human baby in 9 months. Interfering with that process with a drug is a big thing.
Well, we know from experience that that's true, don't we? After thalidomide, we had become extremely cautious about prescribing drugs to pregnant women.
It's quite a complex area, topic of discussion, but I try to keep it simple to some extent that these are chemicals. And so I try to get people to focus on they're synthetic chemical compounds being manufactured in a chemical plant, a chemical manufacturing facility. Then they're going into the mom, crossing over to the placenta, they're going into the baby, and they're having chemical effects. And so that's what the pregnant women and the public really need to be notified and understand that that's actually what's going on. Serotonin plays a crucial role in fetal development. These SSRI chemicals, these antidepressants and others, disrupt that serotonin system. So we would expect to find complications with them and impacts on fetal development. And then that's exactly what the studies are now showing. And right now, the warnings are not good from the FDA on the label, and also certainly from the professional medical societies, which really, if you listen to the follow-up to that meeting, there's very little warning. They're essentially saying that these drugs are really basically without risk, maybe some minor newborn complications, and that they've got these great benefits. And so along with this chemical aspect that I'm trying to get people to focus on, I'd also like to draw attention to the fact that what we're hearing after the meeting, a lot of it is more sales pitch than actual reality of what the evidence is actually showing here.
Let's go on and talk about the impact of a serotonergic drug, an SSRI, on fetal brain development, because that was part of the panel. We heard about basic research on how the fetal brain organizes itself and how serotonin plays a signaling role in guiding sort of the organization. Then there was animal research with rats and I forget what other small animals that showed that in utero exposure altered their brain organization. And there is even evidence in humans that is true. Can you talk about how incredibly important it is to understand that?
Certainly from a fetal brain development perspective, these drugs absolutely impact fetal brain development, and I would say disrupt fetal brain development. So from a basic science standpoint, we see impact from the SSRIs when we look at individual neurons. Neurons are supposed to arborize or send off neurites. That's how they communicate with each other. There are studies out there, one in particular with Celexa citalopram, where if you expose these neurons to increasing doses of citalopram, 20, 40, 60, you can see reduction in the neurites. They look like they're not like a beautiful branching tree the way it should be. They look stunted. So then you go to the animal models, and then the animal models are showing disruption of brain development. We're seeing this from several animal studies where they expose the pregnant mice or rats or sheep to the antidepressants, and then look at the outcomes in the babies, and then their behavior. And we're seeing alterations. We're seeing pregnancy complications, but we're also seeing brain developmental alterations. When those animals grow up into adulthood, they behave differently. They have altered social interactions. And then you move to the human studies. And the human studies are absolutely showing impact on the developing fetal brain. If you look, for example, in utero, there's a few studies that have been done. Mulder in 2011 and Salisbury in 2024 looked at exposure to fetuses in utero, and then by ultrasound, are they moving differently? And they are moving differently. They're showing more jittery behavior, more agitation, less quiescence. Babies developing in utero should be having quiescent periods and active periods. The babies exposed to the SSRIs aren't having the normal quiescent periods. They're acting agitated or jittery. And this is what we're seeing on the ultrasound studies. And we're also seeing that during the newborn period. There's other studies that are done on the immediate newborns or in the children, and these are MRI studies. So MRI is actually looking at the structure of the brain and then looking at functional connectivity. And I made this point at the FDA, but there's now been 12 consecutive MRI studies that have looked at this. So this isn't a one-off, or maybe they got the study wrong. This is 12 consecutive studies showing impact from these medications on the brain. There's also EEG studies, 3 of them now, that have done EEGs in humans, babies, or children exposed to SSRIs in utero, showing different brainwave patterns, showing different connectivity. And then when we study these children growing up as children, then also into adolescence, we're finding changes. We're seeing impacts on speech and language development. We're seeing mood disorders, including depression and anxiety. And we're finding neurobehavioral problems like autism, like ADHD. So the whole model basically fits together incredibly well to show that these SSRI chemicals are disrupting brain development.
That's a nice summary. And I have to say, I would think every woman and father would like to know this information as they look to become pregnant and that sort of thing.
People need to know it when they're considering starting an antidepressant, don't they? I mean, a young woman in her 20s who's thinking of going out may have no idea about having a baby in the foreseeable future. But, 10 years down the line, she might well be thinking of that, and she might still be on that antidepressant and then really struggle to get off it.
This is part of the larger societal problem with the widespread use of this. And this should be part of the informed consent process. I couldn't agree more when you start. I do have a question, though, for you, Joanna. You've studied a lot, in humans, adults, or maybe children too, who go on these drugs, and you see brain changes, right? Are you surprised that it's happening in the fetal brain during that time?
It makes complete sense. I mean, MRIs have enabled us to see quite subtle changes in the brain, and we can detect them when people are on antipsychotics. There are 1 or 2 studies suggesting there might be similar changes with antidepressants. I think the data is less conclusive on that. But the principle is that, yes, these drugs can, alter brain structure in a way that we can visualize. So that suggests they're doing lots of other things that we can't immediately see as well in adults. So it's extremely likely that they are having similar modifying effects in the developing fetus. I think Adam's idea of that these are chemicals having chemical effects is really important to get across to people, not only in relation to pregnancy and the effects on the fetus, but also in relation to just what they might be doing to your brain. We've been fed this myth, haven't we, for years, that your SSRI is correcting your serotonin deficiency, and that's what they're doing. And we know now that that's not supported by science. That was always just a marketing myth. So what are we doing? We're actually putting chemicals into the brain whose effects we do not properly understand. And we shouldn't be surprised if we, see harmful consequences down the line.
And we do know, beyond even the brain organization, we do know that these drugs actually perturb normal serotonin function. And you might think that the fetal exposure is actually then permanently altering the serotonergic function in children exposed in utero to antidepressants. I mean, that's one of the concerns I think is present in the evidence.
So those animal studies showing that the offspring of animals that are given antidepressants show reduced sexual activity when they become adolescents or adults are, they're quite consistent. They were done a long time ago now. Or they've been, they've been well replicated and are consistent with the increasing evidence for this post-SSRI sexual dysfunction that adults report. Now, people who are reporting that are also, many of them reporting that they have ongoing emotional numbing, which is they see as sort of part and parcel of the sexual dysfunction. So I think that, we can see that these effects on the fetus may have long-term effects on sexual functioning, but also on emotional experience.
Jay Gingrich, who was on the panel, has spent a career researching this. And if your listeners to this podcast are interested in looking at this, the study from his group that just came out this year, 2025, the lead author's Zanni, Zanni, is a phenomenal study because it's both the animal and human studies being run together. And it's really a terrific study and a terrific paper showing that exposure to SSRIs during development lead to these alterations in the brain I believe it was mice. And then you can see that reflected in changes in the brain on MRI and changes in response to fear. So it's a complex study, but they exposed mice to SSRIs during development, and then they looked at their fear response. I think they used mountain lion urine because mice are afraid of mountain lions. They used the fear response to that. And they found that was altered in the mice that had been exposed to SSRIs in utero. Then they did the human study in a similar fashion and looked at fear response as well as MRIs, and they found similarities to that. So it's really a dramatic presentation of the chemical impact of these drugs on brain development as seen in the animals and in the humans. But what makes it phenomenal is it's pulled into one study. It's a terrific paper.
I read that paper, and what is amazing when you do see it, you see that this is a compilation of evidence that has gone on for years, decades of research. And you're right, that's sort of a conclusion paper that brings it all together and shows how consistent the evidence is. It's not like there's inconsistent evidence regarding fetal development, that sort of thing. Talk about, and both of you, the baby is born, and then they go through abrupt withdrawal. They go through cold turkey. Can you talk about the hazards associated with cold turkey when you are a newborn?
What's really concerning about this to me is that this has been downplayed. What we're seeing are rates of what's called newborn behavioral syndrome or poor neonatal adaptation or neonatal withdrawal syndrome. And what it is that immediately after birth in exposed fetuses, now newborns, we're seeing these symptoms like jitteriness, agitation, hypertonia, sometimes difficulty in feeding, constant crying, temperature dysregulation. And these babies have increased rates of admission to the NICU. They can also have lung issues, difficulty breathing. So it's often been dismissed or downplayed by a lot of the folks who have been speaking about this after the meeting, but it's a concerning condition in and of itself. ACOG in their document on this puts the rates of symptoms up to 85%. So that sounds like an exaggerated claim if I just said that alone. But no, this is ACOG saying that the rates of symptoms in exposed fetuses, rates of symptoms are as high as 85%. So we see this in a lot of the kids. So this is a problem in and of itself. The babies come out, they're not doing well. It's a problem for the baby. It's a problem for the mom and the parents. Now they've got the baby who's having this difficulty. The other reason I think it's important is what it says about the chemical impact of the SSRIs on the brain. Because even on the FDA label, it says it may be withdrawal, but it also may be direct toxicity. And in fact, the ultrasound studies would suggest that it's direct toxicity because we're seeing these altered or agitated or jittery movements. Then the question is, do these kids that have this newborn behavioral syndrome, withdrawal syndrome, does that have longer term impacts? And there are some studies suggesting that those babies do have more problems in the future.
Joanna, you've been involved with people tapering from antidepressants. You've seen these withdrawal symptoms, which of course are downplayed in adults as well. Can you give a sense of what are we doing to a newborn that their first weeks is this response to life, this sort of entry into like a life?
I suppose, I hear a lot of stories about how awful antidepressant withdrawal is, particularly when people are discontinued abruptly from something that they've been on for a while. And the thought of a newborn baby having to endure the extreme discomfort that people describe. It can be extreme restlessness, also dizziness, sickness, headaches, brain fog. I don't know what that feels like for a newborn, but people describe extreme discomfort. So, you would think that the extreme discomfort that a newborn baby feels is going to be even more extreme. than that which an adult feels on withdrawal. And it's interesting listening to Adam's point about whether this is toxicity or withdrawal. I mean, maybe it's a combination of the two, I would suggest.
Yeah, just from my, layman's point of view, the minute the baby is born, they're starting to respond to their environments, right? That's what the human being is built to do. Those first weeks are so important. You're starting to form connections, that sort of thing. And it just seems almost outrageous that we are exposing the newborn to this early misery.
I was just going to say that. I mean, that's the time the babies just come out for things like bonding, initiation of breastfeeding, things like that. And to be going through that for the baby's standpoint during withdrawal, that's, you raised an important point there. I think I don't take care of adults. I'm not a psychiatrist. I'm a maternal fetal medicine specialist. But what I'm hearing is more discussion about like brain injury or brain toxicity, that this withdrawal that we're seeing and some of the real problems may be a injury, a brain injury, brain toxicity. I'm wondering, Joanna, what you think about that.
Yeah. I think that's a very reasonable view on it, because these are symptoms that persist long after the drug has left the body. So we have to conjecture that the drug has persistently altered something in the brain, which is then causing these symptoms, which then may slowly over time normalize.
And it's not just in the brain. Maybe you're injuring the nervous system at large.
Yeah, absolutely. And probably other biological symptoms. There's a lot of serotonin in the gut. You would expect it to have implications on gut function too.
I just tweeted out a new paper that came out showing increased fracture risk in women who initiate SSRIs between the ages, I believe it was 42 and 52. But we know they also have impact on bone. I make this argument with the fetus that it's affecting the bone, it's affecting the brain, it's affecting the gut, it's affecting the blood system, it's affecting platelets as well, which is very important because that's a major determiner, a major factor in stopping bleeding and not hemorrhaging. And we do, in fact, see increased rates of maternal hemorrhage, of postpartum hemorrhage in moms using SSRIs during pregnancy. So I think the point you both just made on this being widespread, affecting multiple systems, yeah, that's exactly right.
I think one reason you were invited, Joanna, was to answer this question. Are antidepressants effective treatment for the mother?
Obviously, this is the key question. The justification for giving these drugs to women is the idea that they are an effective treatment for depression. And the evidence, which I know well, shows that at best, they are minimally different from a placebo. So the very best view of them is that they might improve your depression experience or symptoms very slightly more than taking a placebo. Now, in my view, that's actually probably not a pharmacological effect, because we know that these studies are unblinded, so it's highly likely to be an amplified placebo effect. But even if it were, it's a very small difference. No criteria for a clinically important difference get as small as the difference you see between antidepressants and placebo. And this is not a controversial point. This is what all the data from all the clinical trials of antidepressants show. It has been massaged. This is the data that's actually collected. These are the depression scores on the depression measurement scales, like the Hamilton scale.
So to play a little bit of devil's advocate here, how about trials in pregnant women who are depressed? Or is there evidence of efficacy? Maybe it's different for some reason in women who are pregnant.
Absolutely not, because we don't have randomized controlled trials of pregnant women. You're not allowed to do trials in pregnant women generally of substances like antidepressants. So no, so we don't have any evidence at all. We also don't have evidence that there is any particular group that does relatively better with antidepressants than others. All we have is this very small average difference between antidepressants and placebo, which to my mind cannot possibly justify the risks that you are running, even if these risks remain uncertain. And I think, most women do have this view that they don't want to put their baby at risk, even if we're not completely sure of the nature or extent of the risk, and particularly wouldn't if they knew how absolutely minimal the potential benefits are.
There are alternatives to drugs for depression. Why aren't we doing that?
I mean, I'm sure people are offered these other treatments if they become depressed during pregnancy. Well, I don't know what it's like in the States, but I would think that generally in the UK, you would initially be offered therapy, and then if that didn't work, antidepressants might be considered, or if the woman had a preference for antidepressants, it might be considered. But another problem is this problem that I would imagine the vast majority of women who take antidepressants during pregnancy were already taking them when they got pregnant. So it's not a case of saying, what alternatives. It's a case of saying, how can we get you off this medication? And then you've got all the difficulties with withdrawal effects.
Now, Adam, as you said, this risk that is posed by antidepressants, using antidepressants in pregnancy, should really be part of the informed consent process when someone begins initiating the drug, when a woman first starts considering whether to take the drug. But of course, what happens is many women are already taking the drug when they become pregnant. So how do you counsel people about this risk, but who are already taking an antidepressant when they become pregnant?
There's really two separate issues or two separate questions that I'm dealing with. They're related, but they're separate. One issue or one question is, do the SSRI chemicals impact pregnancy? Do they cause pregnancy complications? Do they alter fetal brain development? And should pregnant women in the public be warned about this? Those are scientific questions. And I think the answer to those questions is yes. And that's sort of what I spend a lot of time talking about. The separate but related question isn't the scientific question, but the patient care question. And that's what I do basically in my office throughout the day, counseling women about medication use in pregnancy. That's much more variable depending on the woman, and it's much more complex depending on her own personal history, her own personal psychiatric history, her own personal medication history. And so I tell patients all the time, there's no one-size-fits-all answer to this. Typically, what I'll do is try to get their history, a good history from them, figure out how long they've been on the medication and whether they've tried stopping it before, how they understand how the medication is working for them. And then it really comes down to just them figuring out, weighing the risks, the benefits, the alternatives to them from what my counseling is. If a woman's been on the drug, for example, for 15 years, and she's tried to come off before unsuccessfully, had a horrible time, now she sees me and she's maybe 20 weeks pregnant, I would say when I do that 20-week counseling, it's probably like 80 or 90% continue. Whereas when I see patients preconceptionally, which is before they're pregnant, which is really the time that the counseling should take place, we still have that same kind of conversation, but it's different because they're not in the pregnancy, they're planning for it. I would say rates in that scenario are probably closer to 50-50 in terms of staying on versus coming off of the drug. I think a major issue, though, that plays into the question during pregnancy is this issue of withdrawal. It can be very difficult to come off these medications for some people, for some women. And so that then needs to be factored in as a benefit, so to speak, preventing withdrawal. When a pregnant woman is weighing this, the benefit of not going into withdrawal while she's pregnant becomes a major factor here. She may have had other times or other attempts where she's tried to come off of the drug and it's been unsuccessful and she's had awful withdrawal symptoms. And then the idea of trying to face that during her pregnancy may steer her towards staying on the medications. My big take-home message to my patients is I'm going to try to counsel you as well as I possibly can and then support the individual decision that you make.
Do people, when they hear this, they've been on the drugs, say, for example, antidepressants, and now they're pregnant, and now you counsel them about the risk associated with antidepressants in pregnancy, do they ever feel like, oh my goodness, I'm in a trap because I don't want to face withdrawal, but I also really don't want to expose my fetus to these risks?
Absolutely, Bob. That you're hitting the nail on the head there. I think that's exactly right. I think that's why it's so important, and I try to emphasize this whenever I speak about it. It's important that this message gets out to the public, the general public, and to providers who take care of women of childbearing age, because it's really something that needs to be discussed with a young woman of childbearing age prior to starting the medication. And it does create a real conundrum for the patient to then be pregnant and to not have been counseled about this, and then to learn about this counseling, to learn about these things at the time of pregnancy.
So what I'd like to do now is read a couple of the responses and then get you to respond, because that's the narrative that was presented to the public, and that was the narrative that was adopted by most of the major media. I'm going to just read first from the American College of Obstetricians and Gynecology, because honestly, I was a little surprised by this one. I wasn't surprised so much by the APA, but here I'm going to just read it, okay? Today's FDA panel on SSRIs in pregnancy was alarmingly unbalanced and did not adequately acknowledge the harms of untreated perinatal mood disorders in pregnancy. On a panel of 10 experts, only one spoke to the importance of SSRIs in pregnancy as a critical tool, among others, in preventing the potentially devastating effects of anxiety and depression when left untreated during pregnancy. Robust evidence has shown that SSRIs are safe in pregnancy and that most do not increase the risk of birth defects. However, untreated depression in pregnancy can put our patients at risk for substance abuse, preterm birth, preeclampsia, limited engagement in medical care and self-care, low birth weight, impaired attachment with their infant, and even suicide. Unfortunately, the many outlandish and unfounded claims made by the panelists regarding SSRIs will only serve to incite fear and cause patients to come to false conclusions that could prevent them from getting the treatment they need. So, Adam, you're an expert in this field. What do you make of that?
The first thing I noticed with that, and also from a lot of the responses to the meeting, is this focus on depression rather than on the medications. And I try to make the point that, depression is important. I want to step back and just say that it can be awful. Human suffering, people going through depression, it can be an awful thing. And nothing that I say in my focus on trying to raise attention about the effects of the drugs has anything to do with trying to make people feel guilty about being depressed or feel bad or pill shaming or any of that. Depression's important, but you can't answer the question about the drugs by talking at length about depression. When I see a mom in the office, she'll often ask me, what are the risks of these medications in pregnancy? I have to answer that question. And that's what the FDA needs to answer, and actually then have the labels changed appropriately. What are the risks of the drugs, and what is the evidence of effectiveness of the drugs? The second thing that jumps out at me is the statement that there's robust evidence that the drugs are safe. That term, I actually don't like to use the term safe or unsafe because it's an inexact scientific term.
But Adam, they said that. They said that they prevent all these. This organization that is supposed to be responsible for improving maternal health and maternal outcomes said, in fact, that giving antidepressants to pregnant women prevents all these adverse risks, preeclampsia, et cetera. That's not just saying that they're safe. They're saying they're curative. They're preventive. They lower the risk. And to be honest with you, this, there's no evidence of that. Zero. So why do they say it? Why do we have a medical guild saying to the public that this treatment not only helps the mother, but prevents all these adverse outcomes?
That's the sales pitch that I was saying at the start. It changes the mom's brain chemistry, corrects a chemical imbalance, makes her feel better, and then the pregnancy outcomes are better. They're actually, ACOG's actually putting that out there, but that's not what the science is showing.
So the logic is there are, of their position, are that there are these studies which show that there are associations between being depressed and adverse pregnancy outcomes. And if you click on one of the studies that they use to support their notion that depression causes adverse pregnancy outcomes, you will see that this study has not even considered whether or not people were taking antidepressants. They have just assumed that the adverse pregnancy outcomes are due to depression. But no one has any mechanism of how depression, how an emotional state is going to affect a baby. We know that depression is associated with all sorts of things that are very likely to affect fetal development, particularly, socioeconomic deprivation, alcohol use, smoking, other sorts of behaviors that are going to impact the fetus. And so some of these studies control for some of those things, but almost certainly they haven't adequately controlled out all those factors. So the idea that depression causes adverse pregnancy outcomes, in my view, has not been adequately established. And then the logic is that you've got this association, and then of course you take the antidepressant, and because we all know that antidepressants are so effective, the antidepressants will prevent these consequences of depression. Well, none of those things add up. We don't have the evidence to show that depression is actually causing these adverse outcomes, and we certainly don't have evidence that antidepressants can prevent them. I mean, another thing we haven't mentioned is the fact that taking antidepressants is associated with fetal malformations. The association between some antidepressants like paroxetine and fetal malformations is not disputed. So I was absolutely shocked to see that statement that they are safe, because I don't think anyone who knows that they're going to increase your risk of having a major fetal malformation, a majorly malformed heart, for example, would consider that to be safe.
So I'm going to read now something from the American Psychiatric Association, and then we'll come back to this responsibility of medical guilds to know their evidence and be honest about their evidence. But let me just read now what the APA said. We are alarmed and concerned by the misinterpretations and unbalanced viewpoints shared by several of the panelists for the expert panel on selective serotonin reuptake inhibitors and pregnancy panel on July 21st. This propagation of biased interpretations at a time when suicide is a leading cause of maternal death within the first postpartum year could seriously hinder maternal mental health care. The inaccurate interpretation of data and the use of opinion, rather than the years of research on antidepressant medications, will exacerbate stigma and deter pregnant individuals from seeking necessary care. The overall evidence suggests individuals can and should take SSRIs prior to and during pregnancy when they are clinically indicated for treatment. Moreover, recent meta-analyses have found no association between prenatal SSRI exposures and overall risk of birth defects. The dissemination of inaccurate and unbalanced information by a federally sanctioned public panel has the potential to cause harm. It can undermine public confidence in mental health treatment, exacerbate stigma, and deter pregnant individuals from seeking necessary mental health care. Joanna, what do you think of that from your profession?
Well, it's like Adam says, isn't it? This is a marketing pitch to make sure that people keep taking the drugs, don't question them too much, and glosses over all the risks.
But do the professions believe this stuff? Do they know the evidence, or do they believe what they're saying?
So certainly many in the profession do believe it. I know them, and I know that that's what they think. They think that the risks of antidepressants have been exaggerated. I suppose as a psychiatrist, you convince yourself that depression is a real biological condition, and it's really harmful and needs medical intervention. And I think psychiatrists who don't accept that are constantly having to deal with a certain amount of cognitive dissonance, because that is the mainstream view.
Both of those statements are asserting that this is the evidence base. We know the evidence base. And theoretically, a medical guild should know the evidence base. And of course, from the public, you expect them to be honest communicators about the evidence base. But these statements are so at odds with the evidence base. They're best described as just dishonest. And I'm just trying to ask you both, as members or in these professions, do these professional societies believe this, or do they know they're lying?
There's a knee-jerk reaction to defend the status quo, to defend current practice. And I think that I think raising this question, and really highlighting the evidence of, as Adam says, the chemical effects on developing brains, that are produced by antidepressants is one of those really scary topics that the profession wants to shut down, so that current practice, which is doling out these drugs without anyone worrying about them too much, can continue.
I agree with that. I don't want to speak poorly of my colleagues, but I think that professional medical associations, by and large, currently in our society, function more as a branch of the pharmaceutical industry than they do in their actual role to protect and defend and inform the public. Unfortunately, I think that's the case. You've got a book on this, Val, about the guild interests. And I think that, unfortunately, that's how these professional medical associations function. They're funded by pharma almost across the board. But I talk about this a lot where in an ideal world, I think you've got patients here, you've got drug makers here, and the drug makers are trying to sell drugs to the patients, but you've got these layers of protection between them. And those layers are your professional medical societies, your physicians, your researchers, your FDA or European Medical Association, your CDC, your media. You've got all of these in between, actually protecting, defending, and informing the public. That would be your ideal society. But in actuality, that group is essentially working for the pharmaceutical industry to promote the increased use of drugs, to increase sales and profits for pharma. And so I do think that, we need to be aware of this, and that listeners to this podcast need to get that word out and understand that those groups that are supposed to be defending and informing, actually in a large part are working to some extent as a branch of the pharmaceutical industry. And just to finish on that point, this idea that there's no birth defect risk, which the APA put out, it's just really beyond the pale. We know serotonin plays a crucial role in the formation of the heart and the formation of the brain. We know the drugs are disrupting serotonin. So the likelihood of them causing birth defects is significant. And then we see it in animal studies, we see it in human studies. So for a professional medical association like APA to be saying, well, we've got a meta-analysis that basically takes that issue off the board, again, it's more sales pitch, it's more promotional than it is actually informing the public.
I think the profession in the UK is less captured than it is in the US, but the attitude to the use of antidepressants in pregnancy is exactly the same. And the Royal College of Psychiatrists, I don't think receives a lot of money from the pharmaceutical industry at present, certainly not from antidepressant manufacturers, because most commonly used antidepressants are off patent now. So I don't think it's just directly pharma money. I think this whole idea that depression is a medical condition and that medical treatments are the right way to go, it has become crucially important to the identity of psychiatry. And it's really, really challenged by things that really question it. Our paper on the serotonin theory of depression questioned it. And this discussion of the effects of antidepressants in pregnancy also really question it.
I have to say, from my perspective, Mad in America and my own work has really focused on the sense that the public has been fed a false narrative around psychiatric diagnoses and treatments, et cetera. And it's really a betrayal of the psychiatric profession to not be honest communicators of their own research, because the research is there and they're not honest in their presentation of that to the public. And somehow this particular case of not being honest communicators of what the evidence has shown, I find particularly dispiriting, because if you have a newborn who's not having the potential they might be, or less than they might be, or suffering from some disability because of this exposure, that's like a lifelong cost to that human being that's coming into this world. We as a society, what we should be focused on, one of the fundamental things we should be doing is trying to grease an entry into the world that maximizes the potential of those children that are born. And here we are not doing that. And in fact, we're harming that process. And then when I read those statements by these medical professions, and then the media just echoing them like a bunch of parrots, I was so discouraged by the sense of how can we as a society organize our thinking and care, starting with the newborns, around honest science. So it was a really discouraging, dispiriting moment for me. And maybe last words for both of you. What is your own sort of emotional response to the response to the panel?
I agree with you wholeheartedly about the honest communicator aspect of this. And that has perhaps been my biggest frustration in the coverage after the meeting. What was really frustrating is that the honest communicators on this topic are being cast as providing misinformation. A lot of the corporate media coverage, we're calling those of us who are trying to be honest communicators on this and actually get people focusing on what the research shows, what the science shows. We were being cast as providing misinformation. It was awful. It's not just that these professional medical associations and the SSRI advocates are not being honest communicators, which they're not, but it's that they're accusing people that are actually trying to inform the public of misinformation. So that's been a huge source of frustration. I think as a closing note from me, again, would be just to get back to trying to get people to realize that medications are chemicals, and these chemicals are going to have chemical effects. Chemicals have consequences. And so to keep that in mind and to really look into whatever you're taking and putting into your body and during pregnancy or that are going into the fetus.
I mean, like you, I was really dispirited by the reaction, and it reminded me very much of the reaction to our serotonin paper, particularly in the sense that it appeared to be trying to shut down debate to keep the public away from the people who are actually showcasing the evidence that exists. Don't listen to them. Don't listen. Just it's all fine. Just keep taking the drugs and don't worry about anything. I mean, I thought Adam put it very well. Ideally, physicians should be in that middle point, acting as a barrier between pharmaceutical company propaganda and the patient. They should be able to provide the prospective patient with an informed and balanced view of the evidence. And as a profession, we have utterly failed to do that. And as Adam says, acted as just a branch of pharmaceutical companies' propaganda departments. That's really tragic to me. And it was so clearly brought home in that response to the FDA panel and the response to our serotonin paper that the profession doesn't want the public to have an unbiased view of the nature of antidepressants and depression and mental health problems.
Or even sort of open debate about it. I have to say, of course, my profession, science journalism, journalists are not doing themselves proud either. And they certainly embarrass themselves with how they just uncritically took these statements. And then I thought they even piled on. They added their own sort of disparagement of the panels.
There's an ideology out there, isn't there, that that depression is a medical condition, that medical treatments like antidepressants are inherently benign and effective, and it's heresy to question this, and it's stigmatizing and hurtful to people if you dare to suggest that things might actually be different. And it's not just the medical profession or the pharmaceutical industry. Lots and lots of people have jumped on this bandwagon and are promoting this view.
Well, I thank you both for joining us here today. I commend your bravery in doing so, breaking with your fellow professionals. But thank you, and hopefully this can be a little bit of note out there in the world of information that provides a counter to that conventional narrative. So thank you both for taking the time and being with us today.
Thank you.
Thanks, Bob. It's been a pleasure.
Thank you for listening to the Mad in America podcast. For more news, views, and updates, visit madinamerica.com.